Assalamu alaikum. Good morning, everybody. I've always wanted to appear on TV, so that's good. So the talk is about viability, as Dr. Mallah alluded to. And the question is viability imaging still viable? Is it really alive? Now, the background, I'm not going to go into lots of details. It's the last lecture in the session. I'm going to keep it simple. We're basically discussing evidence, which is always a dry topic, but I'm going to try to make it more interesting. So the basic simple question is, first of all, we know that revascularization can improve function in some patients, as our previous colleagues alluded to. Now, does it improve outcome? The other question is, viability testing, according to what we think, helps in selecting patients who are going to do better, but really, does it improve outcome? It's a very hot topic where the internist actually argues for optimal medical therapy. The surgeon goes, let's go for cabbage, and the imager doesn't care, he wants to image everybody. And we really don't know what to do with those patients because we don't have enough data, but we're going to talk about a few trials which are landmarks in the topic. Now, it's a very challenging topic. First of all, the definition of viability, if you even try to read about this topic, you're going to be very confused. What is viability? Some define it as dysfunctional myocardium with no scarring. Others define it as scarring regardless of dysfunction or not. So you could have scar with a well-moving ventricle. The other thing is stunning versus hibernation. Stunning, according to most definitions, is acute injury to the myocardium that spontaneously improves otherwise. Hibernation is chronic or repetitive ischemia that actually responds to revascularization. It's not going to improve on its own. But both of these definitions are retrospective. How do you know, like at the time, that this patient is going to regain function? So they're not very useful in practice, despite being academically glary, but they're not that useful in clinical practice. The other thing that adds to this is if you use dobutamine echo, you're talking about contractility. If you're looking at the myocardium using nuclear medicine imaging, SPECT or PET, you're looking at metabolism. If you're using MR, you're looking at scar. So even the different modalities look at different things. Now, the STICH study is something that we have to talk about today. And it's interesting, while I'm doing this, my kids were sitting beside me, and that's what they thought STICH looks like. And to me, it's actually scary, because STICH looks scarier than this to me. It dented our beliefs in viability imaging. What I'm going to do is I'm going to try to simplify this into pre-STICH data and post-STICH data. So let's start with pre-STICH era. A simple paper to look at is the meta-analysis in JACC imaging in 2002 that actually summed up what we knew before STICH, is that if you have viable myocardium, patients actually do much, much better when you revascularize them versus patients with non-viable myocardium, and you could see the difference in number. Now, the limitations of all of these older studies is that they had smaller number of patients. They were uncontrolled, retrospective, unblinded studies. There was significant bias in many of those since the viability testing actually influenced the decision to revascularize the patient from the start. And it wasn't clear or not standardized what viability means. Every study defined viability in a different way than the other, so we didn't have a standard way to actually measure viability. Many of these studies, interestingly, ignored lots of important factors such as comorbidities, which is a vital thing in such studies. You cannot just check viability ignoring other comorbidities, diabetes, hypertension, function, extent of coronary artery disease. Now, the older studies didn't have the advantage that we have now, neuromedical therapies, and even the imaging techniques are different. And I like the talk that Muaz showed. He showed lots of promising imaging techniques, which if you apply those to these studies, you could change lots of the results. Now, the two prospective studies pre-STICH were the PARR-2 study and the HEART study. Quickly looking at the PARR-2 study, they actually recruited presumed or confirmed left ventricular ischemic dysfunction patients. They had about 218 in one arm, and the other arm was almost equal. The first arm was actually PET-guided. The second arm was standard therapy, meaning that no PET guidance. And in 1 year, the outcome was the same. So PET, according to this study, did not make any difference. However, as was mentioned before, about 25% of the patients did not adhere to the PET recommendation, which defies the purpose of the study. And when you actually take those patients out of the study and recalculate the analysis, PET did make a difference. Looking at the HEART study, where they took symptomatic heart failure patients with ejection fractions of 35% or lower, all with viable myocardium, This shows you how difficult such trials are. They were aiming to recruit 800 or more patients. Due to difficulties in recruiting and funding, they only had 138 patients. And out of those, which were divided into conservative therapy and invasive strategies, only 47% underwent revascularization, which is a very small number. The conclusion of the study is that viability did not make a difference. However, it's extremely underpowered, so you cannot generalize these results. Now let's go to the post-STICH era. We have the main STICH study and the STICH sub-study, and we're going to start with the main study, the bigger one. Both of these studies were actually published as landmark papers in April 2012. So the main STICH study had this question in mind. Does CABG and ischemic left ventricular dysfunction change outcome? They recruited patients from 2002 to 2007. All patients had an ejection fraction of 35% or less. They had about 1,212 patients. They were divided equally into medical and CABG arms, and they followed these patients for about 5 years. Now, if you look at the graphs where you have mortality rates versus years of randomization, you notice that the medical and CABG arms did not differ that much. So whether the patient had CABG or not, there was no significant difference in outcome. That's regarding all-cause mortality. However, if you take the secondary endpoint, where you have hospitalization and cardiac death, or cardiac death specifically, there was a significant difference between the two groups. So CABG was useful. This is a busy slide, but I'm going to try to show one thing only, that there was lots of crossover during the trial. You had about 17% from the medical arm that actually throughout the trial went to the other side, to CABG, and 9% did the opposite. So that actually clouded the results a little bit. Now, if you look at these crossover patients and you remove them from the analysis, you actually have a significant difference in outcome between CABG and medical therapy. And if you do the same analysis to patients according to what patients actually received, not according to the hypothesis, what they actually received at the end, whether it was medical or revascularization, there was a significant difference as well. So if you look at the major analysis, you could argue against CABG in some ways, but if you look at the sub-analysis, CABG was very useful. Another slide to keep an eye for is that patients with CABG had a first month higher mortality rate and complications. So to say let's CABG everybody may be an option, but not a valid option in every patient, because this does not come without complications. Within 2 years, these patients had the same risk as others, but within the early post-operative period, they actually had a higher hazard ratio. So looking at the results of the main STICH study, to summarize things, there was no difference in all-cause mortality if you analyze these patients according to intention to treat, what they really wanted to do initially. However, if you go to the sub-analysis, things differ. If you take out the crossover patients, it makes a difference. CABG actually reduced cardiovascular death or cardiac death and hospitalization, which was the secondary endpoint of the study. And keep in mind that CABG does not come without risk, especially in the first month of post-revascularization. It's very important as well to highlight the limitations. There was lots of crossover. Randomization was actually a very small proportion of the desired number at the beginning. If you look at this, you had 127 sites. Each site recruited about 2 patients per year. That again shows you how difficult it is to actually perform such studies. And what's very interesting is that the main study, or even the sub-study that we're going to talk about, none of them mentioned the fate of the screened patients. We actually looked at the patients who were recruited in the study, but you had a much, much larger number of patients who were not addressed. And this is really a big population. If you have 2 patients per year in the site, you have lots of other patients that you don't know about. Now, the STICH sub-study is more an imaging kind of study where they actually try to address the effect of viability. And the question is, can viability imaging predict improvement in survival? We think the answer is yes, but we're not sure. So that's what they try to do here. It's the same STICH population. However, only half of the patients had viability. Okay, so not all of the patients had viability testing, and that resulted in about 600 patients, which were divided equally into medical versus CABG arms. Notice that part of the problems with this study is that deciding on viability testing was optional. It was the treating clinician's decision. It wasn't randomized from the start. The two modalities that were used to assess viability were SPECT imaging, dobutamine stress echo, or both. And they defined them specifically according to something arbitrary. I'm sure if you ask people who do nuclear medicine here, they could give you different definitions for viability. So what they decided to choose as viable or non-viable is more than 11 segments, which is about 65% of the myocardium. That's for SPECT. And about 5 segments or more for dobutamine echo, which is 31% of the myocardium. And off the bat, even looking at the presentations before, which Maad alluded to, you know that these modalities have different accuracies, sensitivities, and specificity, so you cannot use them both. You either choose one or the other, or do both on all patients. And that was one problem of the study. Even a bigger problem to me is there was no MRI or PET, which is clearly, they're both better studies to assess viability. Again, I like the images that Muad showed where you have discrepancy between the nuclear medicine imaging and the cardiac MR regards the scar and viability, and that actually shows you the extent of the problem. Now, these patients actually were not, the viability was not in mind from the beginning. And what happened with this is that 81% of the patients had viable myocardium according to these definitions. So that means that you only had 19% of patients with non-viable myocardium, which is a big discrepant number, and that's going to give you lots of statistical imbalance when you calculate the results. So what are the results of the STICH substudy? We know that patients without viability actually do worse than patients with viability in general. However, if you actually factor this with all the other comorbidities and other prognostic parameters, this difference did not hold true. So CABG did not make a difference there. And when you compare both groups, there was no statistical difference between both, and the result is that viability did not improve selecting patients who are going to have a better outcome using viability or not. So let's summarize the results again. Patients with viability survive longer. However, that's not true if you factor in other prognostic parameters. The benefit was insignificant when you factor other variables, as we said, and viability imaging did not identify patients who are going to benefit from CABG. Now, what are the limitations? We actually have lots of limitations here. The main ones are, you could divide them into recruited patients problems, imaging technique problems, and reported result problems. Let's start with the recruitment problems. It's only half of the main study population. It wasn't the whole population. It wasn't randomized from the start, and viability was optional. It wasn't part of the study to begin with. 81% of the patients had viable myocardium, which gives you lots of statistical imbalance when you calculate both groups. And the results were not blinded. The clinicians knew about the results of the viability testing. And one very important factor is that the baseline characteristics of patients with viability compared to those without viability were very different. So you actually did not have the same patients to start with, and it makes it more difficult to compare apples and oranges. Now, recruitment, if you notice, started from 2002 and ended 2007, and we're almost 2016 now. Lots have changed in medical therapy and imaging technique. And a few of the new imaging techniques that we saw today actually emphasize this issue. Now, limitations according to imaging techniques, you only use two viability testing with very different accuracies. And you didn't actually define viability in a very standardized way. You could change the definition of the myocardial segments involved, whether in SPECT or echo, and you're going to have different results. Ischemia was not well addressed, which is a very important factor in such patients. And to me, this is a very big limitation. You didn't have PET or MRI in this study, and this would have changed lots of the results. So limitations regarding reported results. They did not report the left ventricular functions and volumes after treatment. We know about those before treatment. And everybody in the room knows that ejection fraction and volumes are extremely important parameter in every single patient you see every day. They didn't even report the outcome of the screen patients, the ones that were not recruited, as we mentioned before. Now, to address that problem, there was a recent paper in October 2015 where they tried to assess patients with poor ejection fraction and normal ventricular volumes to see if that made a difference. Did the patient who had a normal volume do worse or better than a patient who had a dilated left ventricle? And interestingly, unexpectedly, they had the same results. Viability did not make a difference in those patients. And it's not surprising. This same study suffers from the same limitations that we just described in the main and sub-study groups. Just one slide on MRI. I wanted to talk more about that, but I don't think we have time. But I wanted to show this slide. It's always the wrong question. We always have this with the clinician. The question is, do we need MRI in ischemic left ventricular dysfunction? The answer is yes. This is not the question you want to ask us. Because they ask you this, keeping STICH in mind and saying that viability is not viable anymore. But as you saw, and as you're going to see in the next talk, where I think Muad is going to talk about cardiomyopathy and MR is extremely useful in such patients. So the right question is, can MRI detect viability and predict outcome? Yes, that's something that we could debate. But don't ask the first question and expect a different answer. MRI is extremely useful. Now, as we said, it's a hot topic. What's very interesting to me is when you read about this topic, you discover that all these three guys use the same literature to reach different conclusions. They're all the same papers, the same references. And everybody takes the analysis from a different way and reaches his own conclusion to actually advance their own agenda. So it's a debatable topic, but it's not off yet. Let me just show you this debate from JACC Imaging. So the title was, Is Viability Imaging Still Relevant in 2012? And what I like about this, I'm just going to show you the two sides of the coin. On the left side, you have the people who are actually arguing for viability. Okay? On the other side, you have patients who are arguing against viability. But as a cardiac imager, I would like you to see that this guy was more confident than the other, even in his title. So keep that in mind. With this, is viability imaging still viable? I think the door is not closed, and my answer would be yes, despite my bias. And that's up for discussion. Thank you very much.
So we're going to call the speakers to